The other session is on pediatric cataract. I invite Professor S.K. Khokhar sir, who is the chairperson of this session, and Dr. Sweta.
Thank you, Subhash. We just got 30 seconds before we start the session. So all these guys here, I can just want to see the raise of hands. I'm sure you're doing the pediatric ophthalmology. How many are actually doing pediatric cataracts? Can you just see the, oh wow, lovely. Are there some people outside? They can't raise their hands because they're holding the plates in one hand and the cup in the other hand. If they raise the right hand with the cup, it will spill over, and the left hand, the samosa will fall down. I'll request, Amila, can you ask all the guys to come in? If they're interested, yeah. Okay. Okay, so pediatric cataract is another. See, strabismus, when the patient has a squint, parents can see. More than the parents, the relatives can see, and the neighbors can see, and they pinpoint, your son has a squint. I mean, even the parents can't see, because parents can't see anything wrong in their kids. Whereas if it's a cataract, and until unless it's a white cataract, which is in the anterior part, not even the ophthalmologist can pick it up if they're not using a distant direct ophthalmology. That's why the concept of Bruckner's reflex came, that when the kid is there, always dilate both eyes and just run an ophthalmoscope. 99.9% you'll pick up the problem if there are any. But I don't know how many people are actually doing. So this will come a little later, but if we pick it up earlier, it could be presenting as a deviation, or most commonly we see when the kids start going to the school. At that time, the parents realize suddenly he can't see the blackboard. It's not a refractive error, there could be a cataract also. So if it's a zonular right in the middle or posterior subcapsular, it will not be picked up early. So if this kid goes blind and you don't operate in the appropriate time, he'll be in amblyopia, and then whatever you try, red light, blue light, Chinese light, or whatever, it's not going to work to the same extent. All these amblyopic eyes, if they have nystagmus and all, vision seldom improves better than 6/18. So why do you want to go there? Why can't we pick it up early and operate? So now I think time is good. So if there's a pediatric cataract, I'm asking Dr. Bharti to come and take a talk to tell us what are the basic fundamentals in these cases, how to pick it up, when to operate, and then we'll talk how to operate, and gradually I think we'll go throughout. And then later on we have Aditya, who will be talking about the EDOF lenses, how they're going to work in the children, his study. Then of course, we can't have a talk session without Muscati, so he has a myopia control again. Let's hope he talks not about the red light this time. And of course, the glasses has to be given to all these kids before and after the cataract. Even if you put an IOL, you still might have to give glasses. So Dr. Bharti, yours, please.
Thank you, Professor Khokhar, chairman of this session, and Sao Posa, along with Professor Dadia, to have given me this opportunity to share my talk and to invite me here for this session. I'll be talking on pediatric cataract, fundamentals of surgical treatment, and the prevalence of childhood cataract has been reported as 1 to 15 in different studies out of 10,000 children in the developing countries, and they could be congenital, developmental, or traumatic. Now there is a difference, because whenever we see a child, we do not kind of make a diagnosis of congenital or developmental, we just say childhood cataract. So there are little differences in the congenital cataract, which is present at birth, and developmental cataract, which starts developing after birth. And the congenital cataract is smaller than 5.75, and the fixation of the light is absent because it's there since birth, and most of the times you see nystagmus in these children. And they are visually significant, progressive, sometimes bilateral or complete. Whereas developmental cataract, situated outside the fetal nucleus, so it is larger than 5.75. Majority of times the light reflex is present. Nystagmus may or may not be present. Squint may or may not be present. And usually it is partial, and stationary, does not develop, does not increase. Etiology is genetic or metabolic, infective like torch organisms, rubella, and then chromosomal like trisomy 21, 18, or 13, and the skeletal, and idiopathic in 50% of the cases. And here are the pictures of different types of cataract, which are defined here. From most commonly seen cortical and nuclear, but and also punctate the blue dot cataract, which is most commonly seen even in adults also, because it does not hamper the vision at all. History is very important. Most of the time, parents bring the child with the detailed, and from there you get the detailed history. There is history of diminution of vision and does not recognize objects and parents. And white spot in the pupillary area, unsteady eye, deviation, and other such symptoms. And we have to quantify the visual acuity of the child with cataract as precisely as possible. And grade of visual fixation is also important, and photographs. If you can go ahead and take photographs of these cataracts, then you will be able to understand whether they are growing or not. And also you need to screen parents and siblings to rule out the familial causes. Ocular examination includes EUA, retinoscopy, and as Professor Khokhar said, distant direct ophthalmoscopy. The pupillary reaction, the intraocular pressure. Here you see this handheld slit lamp for pediatric examination. This is to carry out, evaluate the size, density, and location of cataract to plan the surgical procedure and prognosis. Squint evaluation, fundus examination should be carried out after pupillary dilation. And A scan and B scan have to be done for axial length, for IOL calculation, and posterior segment pathology, as quite a number of pediatric cataracts are dense and preclude view of the fundus, and the diagnosis is not complete and accurate without a B scan in such cases. Pediatric evaluation, the child should be assessed by a pediatrician to rule out systemic associations, anomalies, and congenital rubella, and the titers for toxoplasma, rubella, cytomega, CMV, herpes. The torch profile should be carried out in all these cases. Every white reflex is not cataract. So most common other cause is the retinoblastoma and PHPV, which are very, very common and give a very white reflex, but the prognosis and management is entirely different. In early childhood, you can find Coats disease, toxocariasis, and hematomas also. And that is why B scan is of utmost importance in condition, as performing cataract surgery in such condition can be disastrous, and also can be, because you have not done the diagnosis properly, can lead to medical legal problems. Laboratory workup is blood test for, including blood glucose, calcium, phosphorus, RBC transferase and galactokinase levels, and torch, of course, is very important, hepatitis B virus. Urine for galactosemia and for Loeys syndrome amino acids, and mostly pediatric cases with the unilateral cataract are mostly idiopathic. IOL power calculation is a very important aspect of IOL surgery. And it also depends at what kind of IOL you are putting. It depends on the age at surgery. And also you have to check the axial length and keratometry, elongation, myopic shift, visual deprivation, and amblyopia in all these cases. And primary IOL implantation is to be standard of care in patients over 2 years of age, definitely. Increasing trends of implanting IOLs in children less than 2 years of age, and for a child of 6 months or lesser, it is controversial to whether to implant the IOL, which many people are doing now, or we have to wait till the age of 2 before we go ahead and implant the IOL. The contraindication for IOL is corneal diameter less than 9 millimeter, extremely myoophthalmic eyes, and poorly formed anterior segment structure. And these congenital anomalies, we must be, very, very careful in implanting the IOLs. Mostly they are, I would say, contraindication. Gordon and Donzi's cross-sectional biometric study of 148 normal eyes found that length increased from 16.8 to 23.6, but refraction changed from 0.4 to minus 0.5. That is because crystalline lens power declined. And that is why there is no proportionately changing lens to compensate for ocular growth. Aphakic eyes have a large myopic shift. So, implantation of an IOL can address this issue, although the initial hypermetropic overcorrection needed may necessitate contact lens or a spectacle use. And anisometropia should be reduced, try to be reduced for embryogenic stimulus it is. And no formula is 100% accurate. Holiday 1, Haggis and SRT give almost similar results. Keratometry, handheld keratometer is the best, and applanation. And
I request Dr. Bharti to conclude.
One slide I want to show here, and this is the Inedi et al. The recommended postoperative refractive goal. This is the rule of 7, and this is very important to be kept in mind. Thank you very much.
I would now invite Dr. S.K. Khokar to present his talk on capsular management in pediatric cataract cases, different strokes for different folks. As we all know, Dr. Sudarshan Khokar is professor in charge of lens clinic services in RP Center, AIMS, New Delhi.
Right, thank you. So I was thinking that he'll talk about the basics of cataract. So basically these are bimanual surgeries, so you need 3 incision and all. So the toughest thing which people found in this surgery is the capsule management. Because these capsules are not same as the adult capsules. So basically what is the concept of the surgery is that you want to make the media clear. If the lens is there, if blocking the light, you just take the lens out of the picture. Even if you don't put an implant, you have glasses, you're still helping the child out. And whenever you do that, please do not eat the entire posterior capsule. Leave a little rim in the periphery, which over the time will become a little harder, and you can put a secondary implant. And this entire procedure should be least traumatic and having minimal collateral damage and minimum complications. So this is what it is. It's not like adult guys, he walks in, he sits in the biometer, you pick up IL power, calculate, hit it, targets, bullseye, always. Like Amila had this lady coming in, he could do it. Whereas the other one is still growing. It's a dynamic. It's like a shooting, like a flying bird you want to shoot. So it's going to be a little different. Okay. So capsule is what is the problem, and we're going to stick to capsule. I think you need a 5mm capsule, so I'll just come to the basics. So this is a slide which I show in all my American Academy courses because this is the basic concept. You have anterior capsule, which is bulging anteriorly, and posterior capsule, which is bulging posteriorly. So your aim here is to keep the incision small and push the anterior capsule backwards, and you can just go in, come, nick from the side, give a nick, use a Utrata forceps. Because Utrata forceps, I think everybody is used to. Make the incision 2.2. If you have a good viscoelastic, it'll stay in the eye, won't come out. And if you don't have a good viscoelastic, which is heavy, anything more than 4-5 million Dalton, you can go with a methylcellulose, but make a smaller incision and then smaller opening. And if in the adults you're holding the capsule 5 to 6 times, here you hold from 7 to 8 times, maybe 2-3 times extra, and you'll get away with that all the time. Okay, so similarly, posterior capsule, once you've done the anterior rhexis, you've done the lens aspiration. Lens aspiration is the easiest bit of the entire surgery. So what you do here is, you put in the viscoelastic in the chamber, not in the bag. Do not inflate the bag because posterior capsule, if you push it further with a heavy viscoelastic, it'll go further away from you. And you will give a nick, it'll open up. It'll run to the periphery. It's inverse of the top of the hill phenomena which you get for the anterior capsule. So yes, go give a nick from the side and come from superior again, because once you give a nick, it's vertical nick, and you can come from here straight, hold the standing edge. It's just waiting for you to catch. Hold it with the forceps. In this case, I'm using a noodles, long forceps, chopsticks, not the Utrata, and go all around, and it will never run. My anterior capsule still runs away in 1 to 2% of a patient. I've been doing this for the last 40 years. But posterior capsule had ran out only 2-3 times. That was when I overfilled the bags and never when it was underfilled. So you can use your chopstick or the forks to eat your noodles, whichever you're good at, but after practice, you will be good at both. So what happens now, different stroke for different folks, if it's not the same thing? Now this video is going to cover up few of the anterior capsule plaques. Let's hope my time is enough. So I'm trying to do a rhexis here. I'm trying to put my needle inside cystitome, but it's not going. That means because this entire thing is actually a plaque. And during those days, we didn't have a UBM. Now we do UBM for each eye, and we can pick up these plaques. So if I pick up a plaque, I'll put a MVR entry from here and cut it. But this one, I was lucky to have a plasma blade with me. And I could just go all around, cut with that. I'm just drawing it on the anterior capsule, and it cuts like, well, that is what is technology. But I'm not here to talk about technology. I'm here to teach you the techniques, how to do it, even if you don't have it. So you can actually cut it with the MVR and take a scissor and cut it all around 360 degree. Okay, so this is what happens after the aspiration, and that's what is my topic. I'll stick to the capsule only. So that's how it looks after the, okay. Now this is another one. Some part is plaque and other part is clear the anterior capsule. So you can try using that, pulling it inwards. So this is where your physics comes in. I think ophthalmology is just physics. Optics is physics, so is the dynamics and the torque and the forces. Whatever we talk about on the cornea, everything is physics, pure physics. So if I'm pulling it, I can tuck it. Always pull it inwards. If you're pulling outward, it will run out. Okay, now this is a third scenario in which even if I pull inwards, my upper capsule part will go out. I don't want it to be more than 6 millimeter at any cost. So once I've done that, some part I do a rexis and other part I give a nick with the scissor. So your scissor, intravitreal scissor has to be there, and if you're not very good at cutting, you can always make an opening inferior also, and this is how it looks like, and the lens can easily go into the bag in these patients. Now this is a fibrotic plaque, anterior posterior capsule all stuck up, so you can't do much in this one, so you have to just make a, now this is what you can try, which I was telling earlier, make a nick with the MVR and cut it all around with the scissor using whichever direction you are. So if you're stuck, you can make one opening and go through. You've got 3 incisions, you can cover 360 very easily in this one. And if you're not from India or Sri Lanka, you're not a great surgeon, you can always put in an implant and go and cut it from the back. I do not suggest that, but people do that. Okay, this machine came into vogue. This was a femto. But the problem is that for anterior capsule and posterior capsule, you have to use 2 PIs. That means double the cost. And most of the patients in which you're doing femto are adults, and they don't have a GF facility in that one. And most of the machines, femtos, are not mobile. You can't shift it from one to another OT. But now we have one LASIK machine, which is Lanka, which can be shifted to the GA side. So I have some videos of that also. So you can do anterior capsule, aspirate, and then you can again dock in with a new one and go for the posterior. It will work. It's expensive. I think that's not the way to go. Okay. Now then came Zapto with David Chang, and this was Zapto is an instrument in which you will go inside onto the cornea, suck onto the cornea, and then you can cut it off. Right. So it's a technology which can work for the anterior capsule, but never for the posterior capsule, because posterior capsule is concave. You can't have a suction on that. So this may work for the anterior, which you can actually do a rexis otherwise also. So it's not a way to go again. So we just got a new kid on the block, which is called the Lensar. So this we got about 6 months back, and we got few patients under our belt. So this is one of the surgeries I'll show, and I think I will be well in time to finish it. Okay, so that's a cataract I picked up. It's not a very hardish cataract, but it's blocking. It's in the middle. It's blocking when the pupil is small. It's blocking. So this is what you have to stain the anterior capsule with the Trypan blue, which the company provides you. The other Trypan blue will also work, and you saw that with a flash of your eye, and this gets over, and that's how fast it is. I'll go back again to this one, since I have the time. Okay, so I'm just focusing the spots, and that's how. So this is the GA. Even adults, if the patient is not even cooperative, by the time he realizes something going on, the rexis will be done. And this rexis is pretty good. You see the measurement, that's a 5 millimeter, and it's covering all around, and you can just pick it up. And then aspiration is the easiest part. It's like a putty cortex which is inside. You can just aspirate with a biomanual, a coaxial, whatever you want. And it's not difficult. So the capsule, and this one, you can do the posterior capsule also after staining. So when you're staining the posterior capsule, since the time is not there, you put in an air bubble and put 2 drops of dye into the bag and leave it there for at least a minute. And go ahead and do it. Nothing will happen. The only thing you have to be careful about is when you focus, you have to focus onto the capsule only. If you focus the anterior, because anterior the cornea can pick up some dye and it will get burnt, or it can have a little reaction. Within a week, it will settle down. But all these patients which we did, where the focus was good, we didn't have any edema in any of these patients. So with that, a difficult step of the surgery can be made very easily, because this capsule size is very important to have the lens in the bag and centration. And you can try any lenses, maybe at a multifocal, monofocal, or EDOF, as my next speaker is going to talk about. And with that, I'll close this talk. I'm well in time. Thank you very much.
It was quite an enlightening talk. As we know, pediatric capsules are not equivalent to adult capsule. Any comments or any questions to Dr. Khokhar?
No question, it's a good talk, right?
Okay. So I would now like to invite Dr. Aditya Sethi for his talk on long-term outcome of EDOF IOL in young children.
Sorry? Oh, we're doing anterior vitrectomy in all the patients less than 7, 8 years. And if a patient is mentally challenged, even if it comes up at the age of 25, I'll still do a posterior vitrectomy and a posterior capsule rhexis because I don't want to go into the OT again because they won't sit on the YAG. It'll damage the lens. So don't be scared of the vitrectomy. Anyway, doing the vitrectomy right in the core and under the capsule all around. So it should be done. If you have a doubt, please do the vitrectomy. But have a good cutter with a high cut rate. Don't have a traction onto the vitreous. That's what is the name of the game.
Dr. Aditya Sethi is consultant ophthalmologist in Arundhya Desert Eye Hospital, Gurgaon.
Thank you so much. Thank you, SAO, POSA, Sri Lanka College of Ophthalmologists, Dr. Dadia and Dr. Maskati for this opportunity. I'm going to be talking about long-term outcomes of implanting extended depth of focus IOLs in adolescent and young children with pediatric cataract. So this is the main question that we've been trying to answer for a really long time because this is what causes amblyopia in these kids is generally the cataract, and after we do the cataract surgery, it's the implantation of a wrong IOL or post-rehabilitation being absent. So just doing pediatric cataract surgery may not be the answer. The rehabilitation is of equal importance. And does the IOL type actually cause an impact on how your rehabilitation will be? So how do we decide which IOL type is most suitable for a child who is still growing? So this was the question which was in my mind. And in the era of EDOF IOLs and advanced monofocals or monofocal enhanced IOLs, it may not, the idea stuck that it may not be right to just go with traditional IOLs. And then we decided to do a retrospective study. So the idea was that traditional IOLs often provide limited to no pseudo-accommodation, which is a concern as the child grows because his life, which is more of near and intermediate, goes more towards distance, and we're not really treating them for near and intermediate, immediate post-op. So EDOF IOLs offer extended depth of focus and potentially increase ability to focus on viewing distances which are concerned to the child. And advanced monofocals, which have given great results in adults, is optimized for near and intermediate vision. And it also acts by balancing clarity and simplicity. And both types are aimed, but which is long-term better. So this is just a comparative case study. This is a boy who's 13.5 years of age. That means he's a teenager. So we chose EDOF IOL in this particular condition. And we noticed that 1 year post-op, in fact, immediate post-op, he started doing much better. And the activities which he was doing, most of them required him to be either with a very small, thin glass or maybe not even that. And that's made his binocularity much better and improvement of his day-to-day visual acuity and the rehabilitation much more lenient. We compared that with a 9-year-old with an advanced monofocal who did equally well, but her dependency on the glasses was a little bit more, even though the glass acceptability was much better. And we compared it with a regular spherical IOL, which was in a younger child, and we found it more tasking and more follow-ups were required to ensure that the dependence on the glasses was maintained. So basically this study is bridging gaps, which is not in the current research armamentarium that we all are used to. EDOF IOLs are not being studied in pediatric cataract till now. And this is beyond the immediate results. The idea is to go long-term, trying to figure out that we will be able to make an impact. And there's the requirement of comparative study has actually been highlighted, and there are implications in clinical practice which come along with this. And this may be one of the first studies which are out there for EDOF IOLs. And the idea about this was only quality of life enhancements. So methodology, single center retrospective study was done. We compared long-term outcomes of EDOF, enhanced monofocal IOLs, and traditional. We had 15 adolescent eyes implanted with EDOFs greater than 10 years of age, and 11 with enhanced monofocals between 1 to 10, and 14 with the traditional monofocal spherical IOLs that we used. And we selected only those eyes which were comparable, did not have any prior ocular surgery, presence of other ocular conditions affecting visual, and didn't have enough data to compare. So the implants we chose were no financial disclosure here. Vivity Alcon, Lucidus, which is refractive EDOF. In the true EDOFs, which were classified with basic spherical issues, spherical aberrations done. We had the Eyehance, the AdTech Comfort, and the EMV, and the monofocal, we had the spherical Alcon lens. So we collected in retrospective way, statistical analysis was done. We had got all the ethical considerations, considering it's retrospective in nature, and we had some challenges as far as data was concerned, but we went in and did it. So the result was the visual acuity improvement was actually noticed to be much faster and much better with the EDOF and the enhanced monofocal IOLs. Of course, these are measured more for distance and intermediate in these conditions, and that's what we showed, that 85% of the patients actually achieved without the need for all the time glasses in EDOF IOLs. Also considering the age, this may be a little biased, but that was the result. And enhanced monofocal IOLs, we saw about 70 to 75% doing better, 20, 40 or better, and this compared to 60% with 20 or 40 or better with the traditional IOLs. We also implied that EDOF IOLs actually give a slightly more higher promising result, and enhanced monofocal IOLs may be replacing the spherical ones as time goes on, as per the statistics. The main concern was amblyopia, and we wanted to compare how the management success was with these lenses. And then we noticed that the traditional IOLs had a great success rate of 70%. The enhanced reached up to about 85% and a rapid improvement. What was surprising with the EDOF IOLs, we actually touched 90% and a rapid improvement in these cases, with inclusive even ocular motility in some certain cases. The spectacle question was something that we wanted to study, and we noticed that the idea was not to make them spectacle independent, but reduce the dependence on these glasses, at least for most of the activity, so that rehabilitation happens with greater success. And that was the case when EDOF IOLs and advanced monofocal IOLs were implanted as compared to traditional IOLs. So in discussion, this is actually filling a small research void. The need for a bigger study, more numbers, and a more impact is still pending, which I would hope that we do in the future. And this is basically a recommendation for your future research, and collaborative efforts have to be done. So conclusion, I've actually left it blank because the study numbers are way lesser than to conclude something very imperative, but of course it opens a Pandora's box, and the question still lies that which is the IOL of choice today. Thank you so much for the time.
Thank you, Aditya. I think we got a minute and a half. So Aditya, one question. You said which was the youngest patient you had here?
So for the EDOF, above 10.
10 years. So they're basically not adolescent. We talk about they're the grown-up kids actually, right? Adolescent, not the pediatric genuine ones. So after 10 years, you can take them as adult only. You can go multifocal, we can go toric also, we do that. The question is, what about multifocals, this one in younger age group? We at the RP Center routinely are using Eyehance. We use EDOF, which has aspheric module. You have a spherical, you have diffractive, and you have refractive ones. Diffractives will work wonderfully well also because your neuroadaptation happens. But calculating the power in those age group when eye is growing is always an iffy thing. So if you put a EDOF, again, whatever lens you put in these kids, less than 2 years, be prepared that maybe 4 to 5% patients will come back and you might have to take them out. So after said that, I think there's no perfect lens. But
we've actually classified them as advanced monofocals, the Eyehance, the EMVs, rather than calling them true EDOFs basically, and kept them between 2 years to 10 years of age. And 10 years above, we use the refractive EDOFs.
Yeah, so that's what I'm saying. So after 10 years, you can consider them as adult and do whatever you want to do, right? Yeah. Except they can't sign their checkbooks and they can't vote. They're as good as adults. Okay, thank you very much.
Thank you,
right?
Thank you.
And now we have no other than Dr. Muscati. He's going to tell some jokes also. And of course, he'll talk about myopia control, not the red lights this time. So Quresh needs no introduction, and he's a gem. He started ophthalmology with his father, I think, a big way, a long way back. You there?
No, I was just wondering why the eye was missing.
Yeah.
So I came there to check.
Are we good?
Okay.
Okay, all yours.
So this is we thank Messrs. SLR, Stellest, for being a big sponsor for this meeting. And this is, they wanted to come in from India. We saved them some money. They donated that money to the Sri Lanka College of Ophthalmology. So I have no financial interest, but I'm giving this talk with slides loaned to me. Many of the slides have been loaned to me by SLR Stellest. So important thing is, if you just remember this one slide from the rest of the lecture, why we are so obsessed with things different from what we used to do. What we always gave what is called single vision spectacles, or SVS, if the patient had -3 myopia and we gave them -3 glasses and the patient saw 6x6, we were thrilled, parents were thrilled, they could see the school blackboard and things like that. And life went on. He came back after 6 months with -3.5, and after another 6 months with -4. And we said, well, his genetics, you know, as the child grows up, he's a growing child, it goes up, with nothing you can do about it, and so on. What has changed is this concept of hyperopic defocus. That when you put spectacles, single vision spectacles in front of the eye, they focus beautifully on the macula over here. So, but the peripheral rays of light, these are biconcave glasses. So the peripheral rays of light are just like they are inverted prism. So they focus behind over here where the red light is. So it's called peripheral hyperopic defocus. So central perfect, but peripheral hyperopic defocus. Now when that happens, the brain interprets this saying that we need to bring the light here. How do we do that? Let's get this sclera to grow. So let the eyeball grow a little bit so that everything comes into myopic defocus. So desirable is this myopic defocus. Everything should focus here. When you don't do it and you give single vision glasses, it goes behind what is called hyperopic defocus in single vision glasses, and that is what causes the progress of myopia. So therefore the optical mode is corrective. If the child is happy, it's corrective, but it's not preventive. In the good old days, about 40, 50 years ago, without realizing it, our senior ophthalmologists used to slightly undercorrect myopes. When you slightly undercorrect a myope, the hyperopic defocus is a little reduced, but then the vision is not so clear at the macula, which again serves as a stimulus for growth. So ideally, you need to correct it with something more than single vision glasses, which can bring all the images inside the retina, or what is called a continuous myopic defocus. Now there are various means of doing this. So again and again, I'm just repeating that if you get this concept of hyperopic defocus in mind, even in the absence of visual signals from the fovea, you can get myopic progression. So if you kill the fovea, in a monkey and scar that fovea, the monkey will still get myopic, this hyperopic defocus and a progression of the myopia. This has been proved by experiments. So this is where there are many ways to skin a cat, and we've got different contact lenses, you've got different glasses, and a little bit from about the Stellest lenses. They provide correction via a single vision zone. So the central vision is perfect. And there are highly aspheric lenslets all around. These are highly aspheric lenslets. 11 rings are there. And this combination sees to it that all the rays of light come to a focus on or in front of the retina. There are different types of special glasses. Two main technologies is the HAL technology or HALT technology, and the DIMS technology. I'll just share with you some of their data on patients who wore Stellest glasses for 2 years, and they found that the myopia progression, 67% wearing Stellest glasses, more than 12 hours every day, and they slow down the myopia progression by 55% for all at an average, and the axial length itself also is slowed down. So both the SER and the axial length progression slows down. This is a 2-year study, and then they went ahead and they found that can the children adapt? Yes. Within 3 days, 90% of children were adapted. Almost all of them were adapted within a week. and 94% felt comfortable with SLR Stellest lenses. Please understand, this is the company which has done this. 94% of no kids are comfortable because they'll complain of pain at the ear, the spectacle becoming crooked in 5 days, but that apart. So these are some of the publications which they have shared with me. 1 year myopia control efficiency, JAMA and other reputed journals which have shown this. Now, because this did so well for 2 years, they moved it on and they said, can we extend this to a 3rd year? So all those, so they had compared initially those on single vision versus those on the Stellest glasses. And they said it's not fair to those wearing single vision glasses because the result was so great. So they shifted all of them, those who are on single vision lenses, to Stellest after 2 years. And they found that this was still efficacious. When they shifted it from 24 months or 2 years, and they shifted them to Stellest, they found good results even in this compared to those who had earlier wore single vision glasses. So this is now 3-year results. The new control group progressed very little again when they switched to Stellest, and the cumulative myopic progression for those of these 2 years on single vision and 1 year on Stellest was again better than those who were only on single vision. So in effect, when you go to 3 years and average it out, this Stellest slowed myopia progression by 1.06 on average for all the subjects. And axial length. So two criteria we always use, SER and the axial length. And the axial length also slowed significantly, and this was statistically significant. So those with single vision glasses, almost a millimeter increase in axial length over 36 months versus almost half that for those who are on Stellest glasses. So the axial length also reduced almost 50%. So this is the 3-year summary. They remained effective over 3 years. They demonstrated a total accumulated slowdown by 1.06 diopters and axial length slowdown by almost 50%. And so they were effective in both reducing slowing myopic progression and axial elongation. In comparison, those wearing single vision glasses, myopia progressed slowly over 3 years, but didn't stop progressing. Then they went on to, emboldened by this, to a 5-year study. And they found that even in 5 years, it remains effective in slowing down myopia progression, even as late as in the 5th year of its use. And axial length similarly slows down by only 0.72. If you remember the 3-year study, those wearing single vision, almost a diopter, but even at 5 years, this axial length increased by only 0.72. So not that it reverses things, but it slows down the progression. So the 4th and 5th year results summary is very similar to that of the first 3 years as well, and that the slowing down in both the axial length and the SER maintained over the 4th and 5th year as well. And these are some of the publications for the 3 years, 4 years, and 5-year control study. Again, this is in the American Journal, which was a crossover study. So spectacle lenses with highly aspherical lenslets, which is the HAL technology for slowing myopia. And this was a double-blind crossover clinical trial, which showed that the data were not suggestive of rebound in myopia progression when patients were switched from SLR to single vision. So if the patient was wearing it for X number of years and then you switched him to single vision, it's not that the rebound occurred. So I told you there were two technologies, HAL versus the DIMS technology. HAL is the highly aspherical lenslets, while DIMS is the defocused incorporated multiple segment spectacles. So there are several companies making spectacles now. There is SLR, there is Zeiss, there is Hoya, and a couple of other companies also which are making these. But since these slides have come to you from Stellest, it demonstrates obviously that HAL is a little superior as far as myopia progression is half that of the DIMS, and axial length elongation is also much less than with DIMS. So this was studied in Chinese children. So they have carefully said that at least Chinese children wearing HAL had less myopia progression and exit elongation than those wearing DIMS lenses. And this is very recent from the ARVO 2024 meeting itself. There were several posters and papers on the HAL technology, which does show that this all of it does work. I won't go into the details of this. So to conclude, this is what the Stellus glasses look when you take special pictures, but otherwise, when the child is wearing it, you can hardly make out that it's different. I have been using these since the last 1 year or so in my practice. So the technology is called HALT or HAL technology, and these are for those who are interested. This is the material. It's of course all 100% UV protected. It also is available now with sun tints. So those who want can wear tinted Stellus glasses. Thank you very much for your attention.
We have some time left.
Yeah. So we'll give you an extra eclair.
Yeah. Any questions or any comments? Sir, I would like to ask, like these glasses are pretty expensive. So in Indian subcontinent and in countries, developing countries, this will burden the expenditure of the parents. So like in your setup, how often do you change these glasses?
Yeah, so one good thing is that these companies are so sure of their product that they give you a guarantee that it will not progress. And if it progresses by more than 0.5, then they give you a free replacement. Within 6 months, if it increases by 0.5 or more, they give you a free replacement of these glasses. They're not all that expensive. If you go for multiple glasses in a kit for 3 to 4 times in 2 years, for example, and if you wear these and don't have to change it for 2 years, it works out almost equal.
It's something like putting IOL in the eye versus giving the glasses, and you keep changing the glasses, or contact lenses for that matter. In pediatric age group, you have contact lenses, the child is going to drop about 3.4 every year, contact lenses, so 3.5. But if you put IOL, you get away. So I think that's right. The cost is...
So the way I look at it is this. Yes, the glasses are a little more expensive than the regular.
Yeah.
But if you can prevent myopia progression, you're later on a person with, I didn't go into all those details, but a person who goes from moderate myopia to high myopia, the chances of retinal detachment, the chances of cataract, glaucoma, increase exponentially, and the cost of this is a huge burden as the child grows up. So if we can prevent it and keep the myopia under control in his growing years, I think your overall financial burden will be much, much less.
Yeah, just a food for thought. This myopia, you're saying, is a mid-peripheral blur, and it causes extension, stops the extension. What about the periphery of the retina? Do you think the periphery is still going weaker and you will have lattices the whole? Anybody has done a study in which they followed these patients for 5-10 years and they realized that, yes, we don't have the substantial amount of problems in the periphery, which can go to RD detachments and all.
Yeah, see, the most studies which have been done have shown that the higher the myopia, the more the risk of peripheral lattice. And so again, if you can slow down the myopia by corollary, it should have less risk of detachment. Lattice is a different thing, but detachment itself, yes.
Yeah. But the thing is that all these studies, I think we all have to have a swept source OCTs to pick up the thickness of the sclera at different levels and then come back with this one. I think most of the studies don't have it.
No.
So now I think we should start doing the scleral thickness, especially if you have a swept source. And you still might have peripheries not getting corrected well. Your central part of myopia might be getting corrected, but axial length is not progressing axially. But the periphery still might be weak in this one. So I don't know, because we had a discussion on this at the RP center, and debate still goes on. Nobody has the answer. So one company says this is working fine. The other company, I'm sure, is going to come out with the answer that mine is better than yours and cheaper also. And we'll give you 2 free. Buy 1, get 2 free. But at the end of the day, it's your call.
Absolutely.
If you're satisfied and the patient is following up with you, the proper centration of the, do you think the centration is the issue in these funds? I mean,
Very much so. You must train your optoms because unless the data is given correctly to Stellest, you're going to have unhappy patients.
Correct.
So one thing that Stellest does is that it comes and trains your optoms for you on the data that they need. So they have to provide the data, the interpupillary distance and things like that accurately. Yeah. And only then will Stellest supply the glasses.
So that's very important. Thank you very much. That was a very good talk.
One last comment I would like to make here, that it is very important to estimate monocular estimation method accommodation lag. Because if there is a lag, then this glass will not work and you will need a addition, maybe a progressive glass will work better in these children.
Absolutely true. And so one of the ways earlier to halt myopia progression was progressive glasses, and multifocal contact lenses were also tried. But they reduced the myopia by an average about 40 to 45% as compared to 60% and more with the DIMS and the halt technology. Yes, sir.
To strengthen the sclera, is any work going on?
Yes.
Any word in the world?
Earlier in the morning I mentioned from China there is a study on using red light 3 minutes a day, twice a day of a particular wavelength, and they feel that reduces the hypoxia to the sclera, and therefore the sclera strengthens, more collagen is laid down in the peripheral sclera, and that contributes to reduction in myopia progression. So these studies are there from China. Yes, Dr. Schultz.
Okay, thank you.
What's the effect of a child's accommodation there? Huge amounts of accommodation.
Exactly what she said the same thing, that this is something that has to be taken into account. There's no such thing as a magic formula in these patients. So you need to estimate your myopia more accurately using an AR machine, auto-ref machine for kids. Is a big no-no because they accommodate hugely, and you need to do subjective, objective, cycloplegic refractions before you fit them onto these, otherwise you'll have dissatisfied patients.
Right. Thank you, Kurish. I think we're running short of time. We had extra time, but then the ESLA people ate into it. Okay, fine. So now we have a lady coming all the way from Taj Mahal, Agra. You from Agra, right?
Yes, sir.
Okay, perfect. So how's Mumtaz? She's doing fine? Okay, good. So she's going to be talking about recent guidelines and prescription of glasses. I think that's the crux of everything. Whatever you do, any surgery, if your glasses are not centered properly, not powered properly, and not checking them and they've got scratches, the parents are not using glasses, it's not going to work. So the media has to be clear, and the glasses are the one which you can take off and clear, not the same for the IOLs. So Arushi, all yours, please.
Thank you. I'm so very happy to be here and extremely thankful for Dr. Dadia for the opportunity and the College of Ophthalmologists for such a warm welcome. So I have no conflicts of interest to disclose. Refraction continues to be the same. What really has changed is the visual behavior and needs of the modern day child, leading to a major rise in childhood refractive errors. So we understand that every child has a right to clear eyesight, and every child who visits our clinics should undergo a cycloplegic refraction. However, not every refractive error that is unmasked on cycloplegia needs to be prescribed. To answer which ones need to be prescribed, we need to know whether they are ambliogenic, whether it is significant for the visual needs of the given child, and whether this error will cause any effect on a strabismus if present. It is not easy to formulate exact guidelines for what to prescribe for each child since there are multiple factors. But the most important considerations are age, anisometropia, and associated strabismus, visual acuity assessments, whether it is reliable or not, how much the child is accommodating, and the risk factors for amblyopia for a given child. We should therefore always try and get an idea of a baseline visual acuity, preferably one eye at a time, using the age-appropriate methods. A dry retinoscopy should be attempted before cycloplegia to help us assess accommodative effort. Autorefractometers for younger children are best avoided. Presence or absence of a squint is important to be judged. Manifest tropias can be noticed the minute a child enters the room, but even in cases where the child has very good control for near and uncooperative for a covered test, just putting a translucent occluder can help reveal a misalignment. Presence of dissociated vertical deviation is almost always indicative of an amblyopia. So which cycloplegic to be used? Is it to be used for all cases? Yes, all cases. Even for the myopes, yes, because then it can help us identify pseudomyopia and accommodative spasms. So which cycloplegic should be used? Tropicamide by itself is not good enough for children. Cyclopentolate is strong enough for most children, and hometropine and atropine, those strong cycloplegics, are more for therapeutic uses. Moreover, there are multiple logistic drawbacks with atropine. So the best way out for children with dark irides is to use tropicamide in combination with cyclopentolate. Cycloacceptance, which is done in the same manner as a manifest refraction, except checking for near, is an extremely useful tool, but to be used judicially. It is best avoided in hypertropia. So in patients where we are getting a hypermetropic component, we can do an acceptance just before installing the eye drops. This helps save a visit for the post-Mediatic test. After dilatation, fundus examination is a must. At least we should take a look at the posterior pole before making a final decision. Now, how do we prescribe? There are many, many guidelines, almost similar and widely accepted. But these are based on practice patterns and definitely not the rule. This chart here is from APOS. The general consensus is that our threshold for prescribing is higher in younger children because they need to emmetropize. However, the minute there are any amblyogenic factors that come into the picture, our threshold goes down immediately. So myopia less than 3 to 5 diopters is not high risk of amblyopia as the near vision remains unaffected. However, when there is a myopia greater than 5 diopters, even in a very young child, we should be prescribing. But if an infant has very high myopia, like a 10 diopters or something, I would probably think of a syndromic association, like Stickner's or maybe retinal dystrophy, etc. Once a child becomes preschool going or school going, they need to see clearly, and we have to correct them completely because they have, for the myopia, because they need to see for distance as well. The aim is to prescribe the lowest minus power needed for best visual acuity. Now, tackling progressive myopia in kids is a work in progress, and what we've learned from the WSPO's consensus is that undercorrection does not work. In fact, it is more detrimental. Only a handful of studies saw benefit from the PALs and hyperopic defocus lenses, hence they are not recommended either. Among others, what does appear to work are the newer DIMS and HAL myopic defocus lenses, which have so beautifully been discussed by Dr. Muscati in the previous talk. In cases of hypermetropia with straight eyes, we prescribe if the error is greater than 4.5 to 5.5 diopters. Mild undercorrection can be done because accommodation is a binocular phenomena and undercorrection has to be equal in both the eyes. We should always rule out an intermittent esotropia, and which may be in the form of an early refractive myopia, refractive accommodative esotropia. Before we put the drops, it should be ruled out. So for first-time hyperopic glass wearers, short-term use of hometropine may help in easy breaking in of their glasses. Coming to astigmatism, a cylindrical power of 1.5 to 2 diopters even can be amblyogenic. That is why a full power of a cylinder should always be prescribed after the age of 2 to 3 years. We feel that the child might not accept it, but young children accept full cylinder extremely well. Once a child is older, if their visual acuity is getting affected, even a smaller cylinder should be prescribed. In these children, the spectacle center is extremely important because bent or crooked glass frame can change the axis, so they should be repaired immediately. Anisometropia, it is an extremely powerful risk factor for amblyopia, hence our threshold for prescribing 2 is low. Prescription should be given at or more than anisoastigmatism of 1.5 diopters and anisohyperopia of 1 diopter. We think that with too much anisometropia, a child might not fuse, but that's not true. Even because of Knapp's rule, even with glasses, they do fuse. Only thing is that single-side high glass may be cosmetic concern, so sometimes to remove the blemish, contact lens may have to be given. Ocular deviation, once it enters the picture, changes our guidelines. And whenever there is esotropia, we have to fully correct the error. For myopia, we give a full correction. For hyperopia, less than 5 years, we give full cycloplegic correction. More than 5 years, we push for the maximum plus that is tolerated by the child. In a case of high AC by A ratio, near ad can be given. In exotropia, we have to fully correct the myopia and astigmatism, can sometimes even over minus. But small hypertropias with normal vision have to be ignored. However, if a hypermetropia is reducing the vision, we have to definitely prescribe, but we choose to undercorrect. Then there are special situations like cataract surgery. In younger children whose visual world is only for near, we give single vision glasses with the plus addition. Once the child starts using down gaze for near, bifocals are given. Sometimes an otherwise healthy child may not be responding to visual stimuli even up to 4 to 6 months of age. They may have something called as a delayed visual maturation. So giving these glasses and +3 or a +4 chances, +3 or +4 glasses suddenly changes their visual behavior. Other conditions like CVI and Down syndrome may also have an accommodation lag, who may benefit from near addition glasses like bifocals. And children with aniridia, oculocutaneous albinism will do much better if an amber or rose-colored tint is incorporated in their prescription. Now, finally, the parents. We need to clear out all the myths surrounding glasses they believe and explain to them that we don't want the vision holding up the general development of the child. And if they like, in future, there are refractive corrective options for them. So, follow-ups. For the first follow-up at 3 to 6 weeks, we assess the glass compliance, fit, look for scratches, etc. At 8 to 12 weeks, we see if the child has improved in vision, whether there is any change in deviation. Start amblyopia therapy is needed. For the first year, the child should be followed up every 3 months. And then depending on age, the next years, 3 to 6 months. So thank you for patient listening and happy prescribing.
Dr. Arushi, it was a very beautiful presentation, well explained. There is a question I have for you. Like an infant, 1 year old, and if he is having a myopia slightly more than what is expected of his age, suppose like -6 or -7 he has, then how will you balance the process of immetroposition and the amount through which he doesn't get amblyopigenic?
So ma'am, most of the times myopia in an infant is not axial. A lot of times it is lenticular or corneal. So we're not really worried about the axial component. However, I would probably undercorrect this child by 3 to 4 diopters. Or maybe if the family is extremely compliant, we can visit them, have them visit us every 2 to 3 months and see how the visual behavior of the child is changing. I would not be, slightly hesitant in prescribing in the first go.
Yeah, the message should be like that. The residual amount of the refractive error should always stimulate the process of immetroposition. So it should always be whatever the amount, the prescribed amount, slightly less than that.
Right, and thank you very much. I think she covered the basics very well. That's where we started, and we got all the machines, LASIK cutting the corneas and all. But the basic thing is refraction under cycloplegia, which she covered very well. Arushi, thank you very much.
Thank you, sir.
Now I'll call upon the speakers to have a photograph here, and we're going to break after that for lunch. And people who are not going to be in the picture, they can go start their lunch.